time was concerned. Now, unlike the paper folder that they have used over the years, they indicated that the paper folder came with various challenges, such as torn papers, fade writing, wet papers, handwriting that cannot be clearly be seen, and other challenges. But these were not present with their experiences with the electronic health record. So they preferred it to the paper folders. Now, the next sub-theme was protection of client data and ensure confidentiality. They shared that client data was protected with the electronic health record. Unlike the paper folder that somebody can carry the folder home. And when you do that, somebody who is not a health personnel or somebody who is not supposed to have access to the client's information can easily have access to it. It was not so with the electronic health record because it was password protected, and you need to have access and be authorized before you can have access to the records. So now I'll move on to the second theme, factors that influence successful electronic health records implementation. This was described in two folds, the technical barriers and then the personal barriers. Now, under the technical barriers, there were challenges described by the healthcare professionals as barriers that influence the successful implementation of the electronic health records. And according to them, the availability of supportive equipment. You cannot use or you cannot store data electronically without computers. So if you have limited numbers of this gadget, it becomes a challenge. And they also indicated that although they had a tablet to support the computers available, it was still not enough. So at times you would have to wait for one person to finish documentation before you can document the care that you are provided to your client or the service that you are provided to the client. And when documentation delays, at times you may miss some fine details. So those were some of the technical barriers. Please, can you? No, you've gone. Yes. And then you know that this electronic health records also uses network. So if your network is very poor, you input something and then it takes a long time for it to be properly uploaded. So you cannot go to the next page if you have network challenges or the network is not working as expected. And then frequent power outages. So you document something and then all of a sudden the light goes off, the whole system goes off. So if you don't have a UPS that is protecting the system from going off when the light goes off, it means that everything that you have documented, if you have not saved it, it also goes off. You also lose that data. So these were some of the things that were shared under the technical barriers. Now, under personal barriers, some of the healthcare professionals didn't know how to go about it. So they linked it up to computer illiteracy. So if you are not a computer savvy person, you are now doing A way, B way, it will take you a long time to type one sentence, and it ends up wasting time. The thing that's supposed to facilitate the work for you wait, and then you waste a lot of time trying to document what you have done. And then others were simply not interested. They were simply not interested in the electronic health record that has been introduced. So they provide the service, they provide the care, and they become very reluctant in documenting what they have done because the system, they were not very familiar with the system. Now, another thing that was shared by the participants was that some were not comfortable documenting full information about the clients in the system because they felt that others can easily have access to the information. So you are at the medical unit and there is a very important information you want to document about your client, but you are very reluctant because you think that somebody else who is not at that unit can easily have that information and probably may not be able to handle it well. So some became very reluctant in documenting full information about their clients, and that also became one of the personal barriers that were shared. Another challenge that was shared under the personal barrier was that when you log in, you use your personal data or your personal details to log in onto your page. And after logging on and finishing, you are done with what you wanted to do for the patient at the set time, you have inputted the information in the system. Some forget to log off. So you have others documenting on others' page. And so when you go into the system, when you put in any information, it is captured under your details. But things are being written under your page that you were not the one who wrote it. So it became a security threat, because if something happens and it is traced to you and you were not the one who wrote it, it means that you were not very cautious when it comes to protecting your own information. And at times, because they also leave the information on the screen without logging off, others who are not supposed to have access to the information ends up having access to the information. Somebody can take a screenshot and then probably publish the information at a place where it's not supposed to be published. Okay. So I will move on to the third point, optimization of the electronic health records. So they shared things like staff orientation and training, because if staff are trained and properly oriented to the system, they will be able to give out their best and use it efficiently. And then also the need for a technical support. So if you are practicing something and you have a technical person that has an advanced knowledge in what you are doing, frequently checking up on you, it will help you do it better and then avoid errors. And then the last one is regular updates of the electronic health records. So if new softwares are out, they were recommending that the one that is currently being used should be frequently updated so that they will have the best out of the service. Now, these were a few recommendations that were made from the study. So, and it's from their findings or the findings from the study. So regular updates of the electronic system to most current version. And of course, this will ensure efficient use of the system to meet the challenging technological trend, which is at the fast pace in terms of development. And it's also recommended that there must be robust security and backup system, so that in case there are challenges, these ones, the data that has been stored will not be lost. And then another recommendation is to ensure the provision of enough computers and tablets so that documentation can be done timely, immediately after the service or the provision of the care. And then it was also recommended that the management should ensure that the computers used at the clinical area with the electronic health records have the possible backup. They should have the uninterrupted power supply to ensure the system runs smoothly without any challenge. And then this will eliminate the fear of having to lose unsafe records on account of unexpected power outage. Because at times it becomes frustrating when you have typed about half a page and you lose it and you have to type again. In conclusion, this research highlighted the various experiences of healthcare professionals, various experiences of healthcare professionals, and various factors that facilitate the successful implementation of electronic health records. And then it has also highlighted the views of the healthcare professionals and made various recommendations that when it is put in place, it is going to ensure efficient and effective implementation of electronic health records in Ghana. Thank you very much.
Thank you, Dr. Agyemayeboa, for a wonderful presentation. Thank you so much. And second presenter is also writing under the sub-theme 3, evidence-based practice, research and policy. Assessing the emergency response capacity and resource availability in the primary health care facility of Ahafo North District, Ghana. To do this presentation is the one who took time as a scientist to write, Mr. Thomas A. Asafo-Adjei. Mr. Thomas A. Asafo-Adjei is an experienced emergency nurse specialist and a member of the Ghana College of Nurses and Midwives. He holds an MPH, a Bachelor of Science in Nursing, an HND in Nurse Anesthesia, and a Diploma in General Nursing with over 18 years of clinical practice and 4 years of tutoring. He brings a wealth of experience and expertise in both patient care and nursing education. He has authored 6 publications contributing to nursing and midwifery research. Currently, he serves as a tutor and clinician at the Nursing and Midwifery Training College and Government Hospital in Tepa, where he is dedicated to shaping the next generation of nurses and midwives. As you have already done, Mr. Asafo-Adjei, welcome to the podium. You have 15 minutes as a scientist to present. Thank you.
Thank you, Prof. Good morning, President, Past and President, and all members here. I'm presenting on assessing the emergency response capacity and resource availability in the Ahafo municipality, that is looking at the primary health care. This came into being due to some practical incidences for which we felt no, we have to find out what is actually happening down. And I'll just talk about 2 of them. One of them was a fall from a height, and a person was asked to go to sent to the facility, that is the primary one. As soon as that patient was sent, he was asked to go to the highest referral center. On getting there, he passed on. The next one was someone who was also sent to this smaller or primary health care center on account of a sudden collapse, for which he also was asked to move on to the higher center. He got there, and when the glucose level was checked, it was 2. In trying to intervene, he also passed on. So the question is, what is happening at our primary health care? My presentation outline is to give introduction, give research the objectives, and the introduction is, we know that primary health care plays a major role when it comes to healthcare systems, especially in our country, Ghana. And because most of our people reside within these places, it means there is the need for us also to have a critical look at this session. And as such, research has shown that even when it comes to sub-African or Saharan, we have about 7 million of our population all residing in the rural setup, for which it calls for critical look for us also to look at it. Looking at Ghana, where we find ourselves, our health budget is not as expected, and with inadequate infrastructure, it means that there is the need for us to have a look at it. So these are some of the main objectives we also set for ourselves, was to see at the primary health care center their preparedness when it comes to emergency response. So the 3 areas that we were specifically trying to work on was to look at the availability of equipment, and also look at some medicine, also to assess the training and preparedness of our nurses and midwives, and also pick out from them some of the recommendations for which they believe can be applied to help improve the services at the primary health settings. The area that we study is Ahafo North, which borders with Bono and Ahafo region as well. It also serves boundaries with a lot of the district within the Ashanti, and it takes care of a population between 93,000 to 35,000. And most of the facilities there are the primary health care givers or the primary health facilities. And as such, it is of importance for us to look at that area. And this were the methodology that was used or carried out to pick information down there. Convenience sampling method was applied, and looking at a nursing population of 240, we decided to pick the 244, our sampling size. The reason is that we felt that if we are able to reach a lot of our nurses and midwives, it will give us a fair idea and also know actually what is happening on the ground. So it's more or less census form of population that we decided to pick. After that, we also use descriptive to also analyze our information. And these were some of the findings. We got to know that when it comes to availability of equipment, and this was also based on the standardized tool that is being used by WHO as well as Ministry of Health. So what we did was that after finding out from the caregivers, that's the nurses and midwives, we also had a checklist for which we verify it by ourselves to see that what you are telling us that you have it at your facility is still there. Because we know that if you are not careful, our people will just give us some information that might not necessarily be reflecting what is on the ground. So what we ask them is that when you tell us that you are having this to use to respond to your emergency, you also tell us, you show it to us, then we take as a correct response that we are giving us. And the information we had, when it comes to our demographic, majority of them were females. But one thing, striking thing that was also very prominent was that we did a correlation analysis and we got to know that not necessarily the years that people have show that they have confidence when it comes to emergency response. But rather, it was education that was also very positive. People who have had knowledge and have skills training showed higher level of confidence. Also, they also made us to understand some of the challenges that comes out when it comes to referral of case. That's when it comes to emergency responses. One of them was when there is the need for them to refer patients, there is a lot of delay. They are also not having their access when they need to communicate. It's also a challenge. They also made us to understand that resources and also support from the managerial system is also a challenge. And some point we got to know that when people are even referring, the number of times that the ambulance will have to spend in coming back to pick the patient, if they are even to send the patient by any other means, it would have been twice of it. So that was some of the challenges that was so clear. And from our information that we also gathered, it was also clear that some basic things such as even oxygen is not available. Suction machines, even stretchers to carry patients are also not available. All of these were challenges that were clearly seen, depicting the challenge that goes on when it comes to a response to emergency. Let's move on. So, from what we were able to gather, it supports some other findings that have been done that shows that in actual fact, when it comes to primary health care, there are a lot of inadequacies when it comes to equipment and also medicine that are needed to use. Also, other research have also shown that there are a lot of things if we are to do it to improve primary health care service in the delivery of their care. So, when we recommend that, all after our discussion and observation, we believe that if staffs are trained, they can be able to provide the needed care. And also the need to strengthen our referral system. One of the suggestions that we picked when we asked them to share their experience was that if, for example, there will be a hotline for which, or they can even create a WhatsApp page for which when they are referring, they can place it on so that the receiving end will pick it without much hindrance. It will help us. Also, the need also to support the environment in terms of giving them the logistics to work with. We believe that if the service, that's Ghana Health Service, can help them in infrastructure, it will also go a long way to help them. Incentives. Some of them, it's not about money, but they need recognition, for which if their services that they are rendering at those facilities are being recognized even by a people to tell them that you are indeed working, it is of value to them. But some of them, they stay there for a very long time and even visit, shadow officers even don't comes on as expected. And for them, they believe that if these small things are done, it will actually help them for also provide the needed care as they need to render to our people. So, we want to conclude by saying that there is also the need for us to look at mentorship, supervision from those who have learned the skills for them to go down and share with others also. And also, there is also the need for people who also have the experience also to go down and also share with him. We also believe that improving all the system in terms of infrastructure and providing them, there are some places you go there, they are there, but they cannot utilize what is there for them to use, meaning that they have, the knowledge is not there for them to apply those things that have been given to them. And some, you can also pay that there are also inadequacy in terms of distribution of those things. I don't know, but that is the observation that was also picked. We end by saying that we are grateful to all partners who help us. This information has been disseminated to the district, and interventions are being put in place to ensure that at least the little that can be done can also be done. We are grateful for other authors also helping us to use their work as reference. Thank you and God bless you.
Thank you very much, Mr. Thomas A. Asafwede. I want to believe he presented on behalf of a group. That's why he kept saying we. We are on our third presentation, which is also under the same sub-theme, evidence-based practice, research and policy, on factors influencing the utilization of sexual and reproductive health services among adolescents at Choko in Ablekuma South Sub-Metro. Ladies and gentlemen, can we wait for her to be properly introduced? All right. They love the Choko. That's why. So to do us the honors of presenting is Mrs. Mavis Amakwe. She appears to be very popular here. All right. Mrs. Amakwe, who is a popular today person, is a committed minister of the Lord Jesus and a principal midwifery officer at the Kolebu Teaching Hospital with over 17 years of experience in midwifery and also working as a public health nurse. She's dedicated to serving and ministering to pregnant women and their babies. Her passion for pregnant women and babies attributed to the success story of the Kolebu Teaching Hospital Pregnancy School. And she started and was part of the pregnancy school between 2018 to 2022. She was an outstanding facilitator during the time. She's also a member of the college and a minister. Mavis is blessed with supportive husband and a son who are members of the new Creators Fellowship. Ladies and gentlemen, help me to welcome Mavis, the minister of the gospel. You have 15 minutes to do us the honors.
Thank you so much, Mama. Thank you so much. Thank you for the opportunity. Wow, it's a great honor, and I want to appreciate and honor President past and present and past, and also our rectors present and past, and all the academic board, and also the leadership of Ghana College for this awesome opportunity. I am very grateful. So my presentation is on factors influencing the utilization of sexual and reproductive health services among adolescents at Choko in the Ablekuma South District. When it comes to adolescents and children and mothers, I'm very, very passionate about them. So this research, what prompted me to do this research was about 7 years ago. I happened to work at the MVA room, and a pregnant adolescent ladies come there with pregnancies that they don't, unwanted pregnancies, and also septic abortion. And I was like, we have so many things out there that you can do. Why don't you do it? And you come, and some of them, to the situation is so bad that you can't even save them. So this is what prompted me to do this study. So the presentation outline, I have my background, my study objective, the method, and the results. So why this study? Why this study? So globally it has an implication in Ghana also, and also on the health care. There's an implication on these people. So global importance, adolescents account for 16% of global population, and they faces high risk of unintended pregnancy and STIs without proper SRH services. And in Ghana, they faces a significant teen birth rate, and that is 75%, and persistent barriers that hinders them from patronizing the SRH services. So these children don't patronize this thing in Ghana because there are facilitators and there are barriers that prevent them from not accessing it, and we'll get to know the barriers. Then the health impact. We have unmet SRH needs lead to unsafe abortion, as I said, maternal implications, and also the generational cycle of poverty. That is where I'm coming from. I'm a guy, so I know that when somebody delivers at that age, that thing actually continues if it is not brought to an halt. Thank you. So my study objective, the specific objective of this study is: 1, I want to evaluate the extent to their utilization. 2, I want to look at their knowledge level. Why are they not assessed? What is actually preventing them from not assessing it? And 3, what are the barriers? And what is influencing this? What facilitators influence these people from not assessing the sexual and reproductive health services that they have around? Thank you. And then these are my methodology. The study design, I use descriptive, cross-sectional. My study setting, we all know, is Choko. And then the sample size, I use convenient sampling. And then also my data, I use structured questionnaires. And also I got my ethical clearance from Ghana Health Services. So the result, I was able to go to I actually had a team of assistants. So we went into the community, we went into schools. I will show some of the pictures, you see some of the pictures, to actually get the people to know what is happening. And we were able to have 243 respondents, and most of them were from the age of 16 to 19. And the highest people were the females, and then I also had some response from the males, but it wasn't like the females. And these people, most of them live with their parents. The level of utilization: half of the adolescents in Choko have ever accessed the SRH services, so they've heard about it. So they can just go there, go and look around and come, because they don't want people to actually get to know that they are there. And the primary access point I realized was the hospital was only 49%, and then the pharmacy was 40%. I was like, the interval between the number of adolescents accessing the hospital is 49, and the pharmacy is just 40%. And with the nurses, we are at the hospital. So what is happening? For the pharmacists to get 40 and we will get 49. This one actually prompted me to also maybe go further to inquire why the hospital is then 49 and then the pharmacy is 40%. Thank you. And then the knowledge. So when you look at the highest knowledge, the people that you know, they know what SRH is all about, they were only 18%. Compared to those who don't know anything, about 35%. And then the moderate, I know, I've heard about it, they are 49%. And then the misconception that they have is that they believe that SRH services are for the married people. So I don't see why I should go and assess that place. They don't see why they should go there. And secondly, too, they said the way sometimes they will get there and the health, we the nurses, the way we receive them, it's not physically encouraging. But I was blessed by one thing about parents. When a mother sent a child to the SRA services, the utilization is high. And it actually blessed me when it comes to this research that I did. Then the barriers, what are the barriers? The barriers, fear and stigma. They fear of being judged by we, the health service personnel. When they come, the way physically we speak to them, so it's like they don't feel like coming because of maybe physical. There's some of the utterances that some people say. Please, not all of us, some people. And then also, they also fear that maybe they are there and someone will get to know, and then their parents will get to know that they've come for what? Family planning. Because I was at Mamprobi, and you know Mamprobi and Choco, the distance is not too far. So the fear of them being seen by a relative who will go and report them to their parents, they wouldn't patronize. Also embarrassment from the health care workers, and also their costs. I heard, you see, adolescents will come, and maybe she has already come to do the procedure, maybe the family planning, she has taken any of the methods, and maybe she doesn't want the method again, but it is not maybe up to 5 or 3 years. And when they come, because it is not up to that time, they are charged. And this is something I witnessed. I had to just actually speak to the midwives that were giving the services. So because of the charges, they prefer being in the house. They prefer listening to other people. And then also, they felt services lack privacy. Yes, where the place is located, it is in the community. So definitely people will see. So there's no privacy. And some actually confided in me and told me that this place, when you come there, someone in my area will get to know. Which actually, it was a big barrier for the adolescent to access the reproductive health services. Then facilitators that promote SRH services. So we have, with facilitators, we need to build more youth-friendly services in the community. But it should be, even though it should be in the community, it shouldn't be in the community. Maybe a little bit outskirts area where the people who will be managing the place are well trained. Thank you. Are well trained. And also the outreaches, even though we are doing it, we should do it more. And peer education, actually our colleagues can influence us. When you get a colleague knowing about sexual reproductive health health services, she or he can actually tell the other colleague if he or she is going through something to actually come and seek for help. And then, as I said, the parental support. I was blessed because any parent that comes with a child to the services, that adolescent has no option than to accept the whatever is being given. Please, can we move? All right. So these are my recommendations. So I recommend to the nurses and midwife practice and health service providers to establish youth-friendly clinics. And this clinics, the people to man, they should be well trained. And also we should strengthen our confidentiality protocols and then expand community and school outreaches. We are doing it, but we can do better. And then policies and future researches. I want to go deep down into the development of parental focused intervention and also the subsidizing of the services and also conduct long-term studies. Thank you so much for the opportunity. I'm very grateful. Thank you, Mommy.
Thank you very much for the wonderful presentation, Mrs. Mavis Amakwe. If we had permitted her, she would have preached as a minister. Thank you so much. And she has a lot to do. She has a lot of future research to accomplish. Thank you so much. The fourth presenter is also under the same sub-theme 3, evidence-based practice, research and policy. And she's presenting on development and implementation of community-based lactation counseling support model in rural Ghana. The presenter, Dr. Adjoa Jemfi, is a lecturer at the KNUST School of Nursing and Midwifery at the Department of Public Health. She started her nursing journey from Agogo Nursing and Midwifery Training College through the KNUST with bachelor's degree and master's in public health. She earned her PhD from the University of Connecticut in the US, and she has won a lot of grants and awards. Amongst them is the 2021 International Society for Research in Human Milk Lactation Training Bridge Fund. She has also won an award from Margaret McNamara Education Grants, USA, Canada Program, Caroline Ladd Wildad Award from Connecticut, Technical University of Munich Award, and host of others. Ladies and gentlemen, help me to welcome Dr. Adjoa Jemfi to do at the honors 15 minutes. Thank you.
Thank you so much for the opportunity. I'm among the congregants, so allow me to borrow from my pastor. Yes, so it's a privilege to be able to share with you one of the studies which was recently done, and I thank the leadership for this opportunity, and then I stand on existing protocols already established. So this work focused on development and implementation of community-based lactation counseling support model in rural Ghana, and it's a collaborative work, so the other people that you find listed there are my collaborators. Thank you. So that's the outline of the presentation. So I know everyone in this room has heard about exclusive breastfeeding. But it will be interesting to you to know that even among health workers, some of us don't define it well. So as a nurse who is interested in this field, when it comes to exclusive breastfeeding, we are talking about giving an infant only human milk. Please, I didn't say any other type of milk. I said human milk. And we are focusing on that for the first 6 months of their lives. So you realize that globally, out of every 10 infants, it's only 4 of them that get to experience this. And therefore, it is concerning for us because they will not be able to get the benefits that we are hoping that they will derive. And so, having been in Ghana and having been well aware of the fact that we don't have lactation counselors who are needed to support mothers who opt to want to practice exclusive breastfeeding, I sought to ask myself, how can I use the little knowledge that I know to come up with something that will bring lactation support right to the doorstep of mothers, so that really through our nursing practice, we can also extend some form of support to these mothers who opt to want to practice exclusive breastfeeding. So for this particular presentation, I am focusing on the protocol that guided this study. So that's what I'm sharing with us. Thank you. So I conducted this study within the Asante Achim South Health Directorate. Specifically, it was within Esubua, Bompata, and Adomfe, that enclave. So that knowing that they are within the same geographical location and making sure that we are following a protocol, we were sure that whatever that we were going to come up with will speak to itself as really what was pertaining to the area. So I used a sequential exploratory mixed methods approach, which allowed us to use a 3-phase approach to conduct the study, wherein in the first phase it was more of using a qualitative approach where we conducted interviews among a cohort of public health nurses, mothers who were pregnant, and then it was also with volunteers, and the volunteers had to come from the community. They had to be people who had themselves practiced exclusive breastfeeding, and they had to be nominated by the community. So following that, in the second phase, we tried to analyze this data, and using the World Health Manual on breastfeeding guidelines and then the Kentucky peer counseling model, we adapted a model that we believed that it was good for our context as Ghana, in that we now called some cohorts of public health nurses and volunteers from these communities, and we trained them for 40 hours. That's about 1 week for each of the cohorts, so that we equip them with adequate knowledge on lactation counseling, wherein the volunteers were to act as peer counseling, where they give direct services to mothers in the community, wherein when they opt to want to practice exclusive breastfeeding, they have 24-hour services from these women. And then the public health nurses acted as supervisors of the volunteers, wherein they were giving referral services in their supervisory role. So in the third phase, that was the intervention phase, which was carried out from the 3rd trimester of pregnancy. That's when the woman was within 36 weeks of pregnancy, so 12 weeks postpartum, when they received 24-hour lactation services, and we collected some data from them as well. So in terms of that results, we realized that these people were within their reproductive age mainly, and then most of them were unemployed, and they mainly were of the Protestant faith. And then in terms of their breastfeeding history, we realized that more than half of them, that's the participants themselves, had experienced exclusive breastfeeding, actually based on record data from them, because we were not there when they were being breastfed. And then they also reported that for their infants that they had also had, majority of them had the opportunity to have also practiced exclusive breastfeeding. And it's interesting to know that this participant that we worked with, they had a higher threshold of wanting to support or recommend exclusive breastfeeding to their peers, friends, and relatives. So as I told you in the first cohort, we wanted to understand what the needs were so far as community-based community lactation support were. So we observed 4 main themes, and these themes had to do with first, education, wherein the participants reported that so far as their communities were concerned, they did not have access to adequate information when it comes to lactation counseling. And then they were also saying that in terms of even the people who are involved, they realized that there was not much involvement from the key stakeholders. And you know, when you give birth in our community here, the key stakeholders, your mothers, your grandmothers, all those big women, and even sometimes our traditional leaders, our queen mothers, they are all part. So therefore, if these people are not really involved, then you could understand why we would have some challenge. Then we realized that they talked about not having access to midwives, telling them that, look, would you want to name somebody that will be your support person in as related to lactation counseling, as related to lactation support when we give birth? They didn't have such an opportunity. Then they were also talking about issues of not having access to resources within the communities that they have so far as lactation support were concerned. And the issue about we having a lot of these breast milk substitutes in our setup was also something that came up. And definitely you and I are aware of some existing misconceptions in our communities which do not augur well for exclusive breastfeeding. Then so far as the gaps for support were concerned, they talked about issue of having to do with education. Where in this time already I said that, look, if you really want to help us, then we want to have access to comprehensive information when it comes to lactation support. We want you, not that when you walk into the facility or you come to us, just within 2 minutes or so tell us about, madam, give your child only breast. No, spend time with us. Help us to really understand what entails into that. Then they talked about issue of home visits. So that if I'm a public health nurse and I should go to a home, I should try to involve the whole family in the education that I'm offering them. And I should make deliberate attempt to spend time to talk about that issue. Then they were also talking about issue of we having breastfeeding social support. So that when I'm pregnant and I come to you as a midwife, please make a conscious effort to want to tell me, to ask me that, would you, or do you, whom do you intend to be your lactation support person? So that that person will from time to time help me with the infant, the person will help me with house chores, the person will even give me access to information, will remind me, will encourage me, because we know sometimes it gets hard. Then they talked about issues of having access to readily available resources, so that we don't just have to be telling them from our head. Sometimes we could have some visuals. We can have some models around where we demonstrate actively to them. Then in the phase 2, where I've already talked to you about, we train these participants who were 10 extensively, and then we equip them with the needed skills. Please, the one which... Yes, and then in the phase 3 is what I talked about, wherein we had the opportunity of now observing the participants, okay, for a period of from their 3rd trimester of pregnancy through their 12 weeks postpartum. And then we realized at the end of the 12 weeks that these women were observed to have initiated their breastfeeding within the first 1 hour after birth. Specifically, it was the 30 minutes. That's what our data showed us. And then we also realized that these mothers were all able to practice rooming in, because we know that when the infant is with you, the tendency for you to want to really breastfeed the infant is increased. And then we also realized that they all had the opportunity of receiving breastfeeding support, because mind you, the volunteers were going to their homes. They also had the opportunity of involving their family members, their friends, even sometimes people from their church there. And then we also realized that they were all able to practice exclusive breastfeeding for 12 weeks. So we recommend that really There are unmet breastfeeding social support needs in Asante Akim South, and then community-based breastfeeding counseling should involve key stakeholders. So with these key stakeholders, we are stressing on the queen mothers, we are stressing on the religious leaders, we are stressing on every one of us here as health workers, specifically the community health nurses, the public health nurses. Let's sit up, let's rise up, and then make conscious effort when we visit our mothers and tell them about the need to continue with exclusive breastfeeding. If they have challenges, let's try to see how best we can help them address. If it's beyond us, please don't feel shy to refer them to your superiors or people who can be of help to them. Please, if we don't do something about this, we realize our rates will be going down. And we know that when an infant is exposed to human milk, the benefits outlive just the infant stage, and it's for life because it has a permanent health imprinting for them. And we are very much aware of the benefits, which includes limiting some cancers, inclusive of what? Breast cancer, ovarian cancer, and all the likes. So please, let's get passionate about this. Let's involve ourselves in this. Then we also realize that it would be very helpful for us if we could find a way to integrate this model into our existing primary health care model. And we believe that findings of these studies, as we disseminate with honorable people like you, and as we also put it into the literature, other similar jurisdictions may use it as a reference to adapt. And it will help us to see similar positive results wherein the health of mothers and children in Ghana, in the sub-region, and globally could be improved. So these are some of the references. And I'm so grateful to my founders and specifically every one of you for giving me audience.
Thank you. Please, you can take your seat. So far, the scientists are doing well. They are managing their time very well. They've not exceeded the 15 minutes. So you are doing very fine. The last but not the least is our own Sauda, Mrs. Sauda Isaka Aye. She is presenting on a very interesting topic. Professor Ampointe says something. Most of our nursing and midwifery researchers have been centering on qualitative, and she's also doing the same. If you don't have money, you will die. Experiences of family caregivers of children in Ghanaian hospitals. She is also on the third sub-team, evidence-based practice, research, and policy. She's a certified pediatric nurse, holds a Master of Public Health degree, and is a fellow of the pediatric faculty. The pediatric faculty chairperson. She has been very instrumental in developing the pediatric program, continuous professional development courses, faculty capacity building, and resident training. She is a recipient of the Maiden Ministry of Health Annual Nursing and Midwifery Excellence Award in 2021. She has several publications to her credit and is currently a student in the PhD program at the University of Ghana. Sauda, you are welcome to the podium. You have 15 minutes to do presentation. Thank you.
Thank you very much. Thank you very much, Professor Chair. Permit me to stand on existing protocols. Yes. All right, so the title of my presentation, as reiterated earlier, if you don't have money, you will die. Experiences of family caregivers of children in Ghanaian hospital. My co-authors on this study are Professor Lillian Akofa Ohene, Dr. Emmanuel Pabi Abekwe, and Professor Lydia Aziato. The outline of my presentation is on your screen. I believe all of us here have had the experience of having a dependent on admission. We all can attest to how it alters your normal or daily routines. At least you have the obligation of visiting the hospital to attend to one or two needs of the person, and you may be able to attend to your businesses and then go back again when necessary. When it comes to children, it is even more pronounced, because with children, beyond it being an obligation or you wanting to be there for your child, our healthcare facilities actually require you to be present to care for your child. This poses a huge burden on parents or families who have their children in hospitals. In Ghana, currently, there isn't enough data addressing this concern. So we took it upon ourselves to explore caregivers' experiences during the period of hospitalization of their children. We opted for an exploratory descriptive study, conducted it in 2 tertiary facilities within the capital city. We used the maximum variation sampling to ensure that we recruited all forms of caregivers within the facility caring for the children. We used the semi-structured interview guide to conduct face-to-face interviews with caregivers within the facility. We attained saturation on the 20th participant. Prior to data collection, we obtained ethical approval from Ghana Health Service. We also sought permission from the facilities in order to access the units and interact with the caregivers. And for the caregivers, they were given detailed information about the research, and they consented to taking part before we conducted our interviews with them. All interviews were audio recorded. Recordings were transcribed verbatim. After cleaning the data was entered into NVivo software student version 15. We conducted thematic analysis, and now to the results. For the demographic data of our participants range between the ages of 23 to 40, 31 years to 40 years accounted for 7 of the participants. 9 of them were between the ages of 41 to 50, and between the ages of 51 to 55, we had 1 caregiver. Most of our respondents were female, which is not surprising looking at our cultural context. In terms of ethnicity, we had Ewes, Gadangme, Akan, Mamprusi, Dagomba, Kotokoli, and Talensi tribes featuring. Then for marital status, most of our caregivers were married. In terms of relationship with the child, 17 of them were biological parents of the children on admission. 2 of them were aunties, and 1 was a former caregiver who cares for the child from an orphanage. In terms of religion, the majority of our participants were Christians and were also interested in how long they had stayed in hospital. They indicated they had spent between 2 to 14 days within the healthcare environment. One main theme emerged from the data with 3 sub-themes. The main theme is caregivers' experience, and then the sub-themes included family-centered care, care satisfaction, and financial drain. With family-centered care, all family caregivers indicated that healthcare professionals had provided them some orientation about the approach used within the healthcare facility and encouraged them to stay with their children. They also indicated they were involved in the care of their children as they supported the children with activities of daily living and any other support that healthcare providers needed them to support with in the care of their children. Here are some quotes from our caregivers reiterating the concept of family-centered care within the facility. One said, they said it is family-centered care, so they involve us, the parents. Another indicated, as a mother, I am always there for him, financially, physically, emotionally, and spiritually. When he was going for surgery, I went with him to the theater. Now to the second sub-theme, which has to do with caregivers' perception or their satisfaction with the care that their children received. Almost all caregivers were satisfied with the kind of care that had been rendered to their children in those two facilities where we conducted the study. They were very appreciative of the effort of the healthcare providers. And for some who had tried other options before coming to these particular facilities, they were even more appreciative of the services they had received there. To buttress this point, a caregiver indicated the progress the child had made from the time they came in to the time we were interacting with them. The participant indicated he is recovering gradually. There is progress in the hand they operated. The nurses are very good. They don't compromise on care of children. There was one participant who was not too excited about the care received, but even with that, she acknowledged that it was more of a systemic problem than an issue that had to do with the individual professional. And this was what she had to say. My expectations have not been met 100%. Sometimes I feel they lack the necessary logistics to manage them. This is what they have available to them, so we will take it as it is. To the final theme, which is financial burden. The financial challenges hospitalization of children posed to families was overwhelmingly present. They lamented the high cost of care and the unplanned purchases they had to do. A healthcare provider indicated she had the unfortunate event of having to spend a few days and then carry her sick child home because they could not raise funds to support the needed surgery for the child. This was what she had to share. I am very worried because if we had the money, he would have done the operation. They would have done the operation for him so that he would be free of the pain. But now, I must take him back home without the surgery. I also have a quote from a parent who had the unfortunate situation of having two of his children on admission because they sustained burns. He was overwhelmed with the cost of treatment and had this to share. In this life, if you don't have money, you will die. They are always prescribing drugs for us to go and buy. It is draining me financially. In conclusion, I would like to reiterate that our findings were consistent with other studies that had been conducted in this area within our Ghanaian context, also highlighting the socioeconomic burden of hospitalization of children. In relation to other studies globally, there was some contradiction in that for them, the key issues were more of emotional stress. And that is understandable because in their setting, you don't necessarily need cash in hand to receive care. We therefore recommend that family-centered care should not just be something we verbalize, but it should be something we practice and should go beyond just encouraging family presence and involvement in care, but to also actively provide support for families of children who are on admission. We also encourage further research to explore supports that can be available within our healthcare facilities for these caregivers. We're also appealing that for patients who are on the National Health Insurance Scheme, there shouldn't be that requirement of some deposits for some care to be rendered to them. And where applicable, it would be ideal to institute a sliding scale payment system where the affluent pay a bit more, and then those who are financially constrained are given bills within their economic circumstance. Patient and family education should include support services, financial, social, psychological, and spiritual services. These are some authorities that supported the work, and I'd like to use this opportunity to acknowledge my supervisors, and then Banga Africa for financial support for my studies, my colleagues at School of Nursing, University of Ghana, and Right to Finish Academy or club members, and finally to the caregivers and research assistants that made this work possible. Thank you.
Let's give it up again. Thank you very much, Mrs. Aye. Now, the other four presenters, kindly join her on stage as you respond to questions and contributions, concerns. I believe that throughout their presentations, you have written your concerns, your questions, and other issues down. So, Dr. Ajimayebua, please kindly come up stage. Mr. Asafueje, Mrs. Amakwe, please join us. Dr. Jemfi, and then our sister is already seated. Please, let's come up stage. We are going to entertain questions, concerns. If you have any constructive contribution you want to give to the paper, it is welcomed. We are still within time. We are doing this within 20 minutes. So please, if you want to ask questions, please take your seats. Thank you, ladies and gentlemen. Welcome to the stage. Please, if you have a concern or question, kindly raise up your hand, then you can. Thank you. Others, all right. So let me take the first hands, please. Let me see you. So he is 1, you are 2, 3, 4, 5. After the first 5, then we'll take the second round of questions and contributions. Then we'll call this session off. Thank you. Please introduce yourself. You ask your question. Please direct to the one you want to respond.
Okay. Good morning. Please, I am Bernard Bedubuama from Oncology.
Please, Kasamemem.
Thank you. This is Bernard Bedubuama from Oncology. And my question is to Dr. Joanna Ajimayebua. She presented on the experiences of healthcare professionals. And I wanted to find out from her if she can share with us some of the limitations to her study. And then, how did you test for rigor in looking at credibility, transferability, dependability, and then conformability with regards to your study? And then to the third presenter, Madam Mavis Amakwe, in your presentation, I saw that you had a sample size of 243, and you were talking about Choco being your targeted population. How did you arrive at the 243? Thank you.
Okay, so please, can we maintain silence? We are still doing scientific session. So please, she can respond. If I can crave your indulgence, can they sit down to take the questions? Thank you.
Okay, thank you very much. So thank you very much, Bernard. His first question was about implications for the study. That's what I... Limitations. Okay. All right. So one major limitation was the fact that the researcher conducted the study at her place of work. And to prevent this, she bracketed herself from the data collection. And the first step of the data collection, that has got to do with recruitment of participants. So she ensured that others who were not directly involved with the study supported her with the contacts. So the participants only got to know that she was the researcher at the date or on the day that the data was being collected. That was one limitation, because if you conduct a study with people that you are very familiar with and you approach them and you request that they participate in your study, they may not want to be part, but maybe because of the relationship that you have with them, they may not be able to tell you. So that was one limitation that was addressed by the researcher. And then the second bit was on how rigor was ensured during the study. Yes. So one of the things that was ensured was to collect the data. The interview period, it was between 30 to 40 minutes, and it was conducted at a place of convenience for the participants, and it was tape recorded and played back to the participants for them to confirm that what you have captured is exactly what they said. And then also the methodology was explained very well in the main write-up, so that somebody who wants to replicate the study can also replicate it without any problem. So if you go through the main study, you really see a proper and detailed description of how the participants were recruited, how the data collection tool was formulated, and then, okay. Thank you very much.
Thank you for the response. I believe he has gotten what you want. Mrs.
Well, thank you so much, Brother Bernard, for the opportunity. So there's this formula that we call the Cochrane's formula. That is what I used. And when we close, you can have a sample of it. So the total population of the area, we had about, please, I'm coming. So when I actually did it, there were 384.6. But those that answered were the 243. And the population, the totality of the place, we had about 1,800. Thank you so much.
Number 2. I gave numbers. Number 2, please. Please, I can see some empty chairs. Where you are coming from, if you can get closer.
Good day, please. I'm Thomas Mfi, Pediatric Nursing Faculty, Kumasi site. My go to Auntie Sauda, our favorite friend and faculty chair. And then partly to GCNM. I'm passionate about this because maybe I secretly role model you since 2016. When we met first at Tamale. I'm grateful for the opportunity. Similarly, I'm doing almost the same, but mine is on Ben's. Experience of caregivers in that respectful area. So I want to know about the sliding scale. When you presented, I asked, shouldn't you be given the opportunity to say this before the Minister of Health? Is GCNM, will you facilitate this so that they get to understand that care is really expensive, though we are using the health insurance scheme? How can we help implement this beautiful proposal made by Auntie Sauda that we can have conditions that are not covered by the health insurance, or those who pay, we have the poor of the poor. What percentage should they pay? And those who can afford, how can they complement our effort? And Auntie, how far do you intend going with this proposal? Thank you for a beautiful job. I'm done.
So I think what Thomas gave us is more of a contribution than a question. But I just want to add that, yes, sharing our studies is a way of sending the message out. Within the nursing fraternity, he gathered here, there are people who have a seat at the table. So I believe that some of the recommendations we're putting across here will be tabled at the appropriate places. And when we also have the opportunity to push the agenda, we will do our best. Thank you.
Thank you. Good morning. My name is Habibi from Takwa. I share in the sentiments of my colleague who just stepped out, but I would like to comment on the human breastfeeding. From the policy perspective, I believe that such researches are not meant to hang on the shelves and go dusty, or they are not meant to stay in conferences like this. We would want to drive it and see it in action. So from a policy perspective, and it's an appeal to the change makers here, if we have the power or we have a certain level of influence, are we able to push so that maternity leave for women will cover the duration, the expected duration for exclusive breastfeeding? And I am especially moved, having been a breastfeeding mother myself in the last couple of years. It seems as
Hello, please. Thank you.
Yes, so we tend to preach virtue and practice vice, because after all, you have to resume work after a couple of months after delivery. And so if you're unable to save breast milk, for example, if you're unable to freeze it, or you don't even trust that the cold chain is okay, is safe, you may want to fall on formula, which happens to be more convenient but could give you issues. You know, but you choose the best of the evils. So as change makers here, are we able to push this so that we can reach the optimum? If not the best, we should meet halfway, and then we are also good examples to the people we preach to. Thank you.
I thank you.
That is an interesting point that our colleague has just raised. And we believe that it's more of engagement, because advocacy doesn't start in one day and end in one day. So the conversation has always been existent, but it's now time for us to put in more, and based on evidence that comes out from such work as others have been doing and we are adding on, and future ones, and continuous engagement, we believe that some proactive policy decisions can be initiated and continue. Thank you.
Number 4.
All right. Thank you very much. My name is Jonah Ayamba. I'm at the pediatric oncology. I did pediatric oncology, and I have a question for Ms. Mavis. During your presentation, with regards to the access points of our adolescents, you mentioned 49 for the hospitals and 40 for pharmacies. We didn't see where the 11% actually access theirs. I'm asking this with the idea that if we're able to understand the access point for the 11%, it will give us the opportunity to come up with strategies on how to increase the accessibility towards the hospital sector. Thank you.
Well, thank you so much, sir. So I gave 2 main access place, because on our questionnaire, when we asked them, these are the the answers we got from them. And if you add the two, making 89, the rest have not even accessed it before. That is why you didn't see anything. But we also, as I told you, my passion is on we making sure these adolescents come to the hospital. Yeah, so as physical nurses, we have to, the way we have to open up for them, all right, when they come, the way we receive them. And also, as I said, hello, please. And also, as I said, the policy makers, okay, we should also make sure that the adolescent candidates are at a vantage point where they can actually assess without being stigmatized. These were the things that I said. Thank you so much.
Thank you. The fifth person.
Yes, thank you very much. I'm Edith Chumwa Mavis, Faculty of Family Health Nursing, and my background is a public health nurse. So, Mr. Thomas A. Asafo Ejay, this question is geared towards you. Yes, assessing the emergency response, capacity and resources available in the primary health care facilities. And one of your recommendations was intensify supportive supervision. And I've worked for almost 8 years at the District Health Directorate. And as a CHIPS coordinator, we always want to go for supportive supervision. And where I work, Kogu Franklins North District, our facilities are very scattered, and we can spend 5,000 or more to visit a facility on the island. So, intensifying our supportive supervision, we wish to always visit our facilities, but this is the constraint. So, say, how can this, we having this financial constraint to visit our facilities, how possible can we do this supportive supervision always? And my other questions geared towards Madam Ajua Jenfi. Yes, developing and implementing.
We don't need you to repeat the title.
Yes,
ask your
please.
question. Thank you.
For her recommendation also was, yes, on, yes, her writings, the counseling, the model. I want to find more or know more about how the model we can use to train our community volunteers back at the facility level or the community level to empower them to intensify the counseling. Because some of the facilities, we only have one community health nurse running a facility and serving about 10 communities. So how can we train and motivate these community volunteers to do the counseling for us for our exclusive breastfeeding message to spread? Thank you.
Thank you. Let me begin with you, Dr. Ajua Jenfi.
Thank you so much for this important question. So the good thing for us is that when we look at our primary health concept in Ghana here, and the concept of the CHIPS, community-based health planning services, we have the public health nurses, the community health nurses, the engagement of the various key stakeholders, being active players. So the good thing is, once there is this kind of buy-in already in existence, I believe that we who may be at the CHIPS compound, we should employ our